Hello, everyone, and welcome to this session of AAC in the Cloud. We're excited to have you here. Today, we have with us Sarah Price Hancock, and she will be speaking on electrical injuries, speech communication disorders, and AAC. What's the next step? So we'll turn things over to her. Thanks, Sarah.
Thank you, Melissa. These slides can be downloaded through the aacconference.com website, or they will also be available for download on ResearchGate. I'm going to use my speed device because my speed is slow and hard to understand.
By way of introduction, I'm Sarah Price Hancock. I am a third-generation San Diegan. I am an alumni of Ricks College, made famous by Napoleon Dynamite. I graduated with my bachelor's in English from Brigham Young University in 2002. I got my master's in rehabilitation counseling from San Diego State University. I am a nationally certified rehabilitation counselor. I have a graduate level certificate for psychiatric rehabilitation. I taught psychiatric rehabilitation at San Diego State University at the graduate level and worked as a research specialist on federal grants until delayed electrical injury and the aging effects of repetitive traumatic brain injury made working full-time and later part-time impossible. At this time, I am a member of the UK ECT Improving Standards Campaign Group, a stakeholder group for United Kingdom's National Institute for Healthcare and Excellence. I'm a BYU Idaho Professional Alumni Mentor, TBI Program Committee member, and TBI Peer Support Specialist Curriculum Mentor for the State of California's Department of Rehabilitation. I'm also an advisory council member with Disability Rights of California for the protection and advocacy of people with mental illness. Though I volunteer with these institutions, I am not giving this presentation on their behalf. The opinions expressed are my own. At this time, I use ProLoco for text on a Wego 10A device with either a cable keyboard on my screen or a wired keyboard. I am in the process of working with my speech-language pathologist to begin learning to use a switch because both my spasticity and my weakness are gradually becoming more frequent and more profound. We're also exploring eye tracking options. I will discuss these complications later in my presentation. I am blessed to have had the opportunity to voice bank and create my own voice through a cappella. Gratefully, Team Gleason provided a scholarship to generate a voice like mine. This was no small miracle. I believe in miracles. I have seen many in my life. We'll get into some of them later in this presentation. Technically, I'll be talking about what electrical injury specialists refer to as both the immediate and delayed electrical injury. Delayed electrical injury can happen between 6 months to more than 10 years after the initial shock. W86.8xxs is the International Classification of Diseases billing code for following up on someone living with electrical injury. We'll examine what we know about physiological causes of electrical injuries, sequelae on communication and speech by examining complications caused by electroconvulsive therapy. The International Classification of Diseases acknowledges delayed ECT effects. Y84.3 is the ICD code for shock therapy as the cause of abnormal reaction of the patient, or of later complication, without mention of misadventure at the time of the procedure. To outline the entire presentation, first, I'll touch on explaining electroconvulsive therapy. Second, I'll explain how ECT causes a repetitive mild to moderate traumatic brain injury. Third, we'll discuss how non-ionizing radiation compounds repetitive traumatic brain injury causing brainstem, trigeminal, and vagus nerve dysfunction. Fourth, I will explain speech and communication disorders associated with repetitive traumatic brain injury secondary to the neurological sequelae of electrical injury. Fifth, I'll share how alternative augmentative communication can improve quality of life. And sixth, I will brainstorm considerations that should be made when assessing AAC needs for someone with a history of chronic non-ionizing radiation exposure. Information in this presentation can be used by speech therapists, physiatrists, neurologists, and other medical and rehabilitation specialists desiring to better understand anyone with a history of repetitive electrical trauma or repetitive, prolonged exposure to pulsed electrical and electromagnetic fields. This includes electricians, welders, veterans, and others injured by electricity on the job, at home, or in a medical setting like electroconvulsive therapy or transcranial magnetic stimulation. Before I continue, let me preface this information by acknowledging the data presented is gathered from peer-reviewed research, real-world evidence presented in 4 case studies, and my personal experience living life after ECT. Nothing presented in this presentation is medical advice. It is presented for informational purposes only. That said, information presented on electroconvulsive therapy may be traumatic to ECT recipients or their loved ones who were not properly consented to treatment. For that, I genuinely apologize and acknowledge ongoing efforts worldwide to improve informed consent. To better understand the long-term consequences of pulsed high electric and electromagnetic fields known as non-ionizing radiation, my presentation will focus on people with a history of electroconvulsive therapy, or ECT, also known as shock treatment. Looking at people with a history of ECT and transcranial magnetic stimulation to better understand non-ionizing radiation was first recommended 20 years ago by the United Kingdom's National Radiological Protection Board. Their advisory group on non-ionizing radiation published a report entitled ELF, Electromagnetic Fields and Neurodegenerative Disease. This report details how people with chronic exposure to pulsed non-ionizing radiation have a higher rate of subsequently developing amyotrophic lateral sclerosis, Parkinsonism, and Alzheimer's. The first report of a person with electrical injury subsequently developing amyotrophic lateral sclerosis was made in Munich Medical Weekly back in 1906. Since then, subsequent reports identified that of ALS's heterogeneity, the disease in people with a history of electrical injury is uniquely slower than genetic or other spontaneous forms. Information linking pulsed high electric fields and the subsequent development of ALS was highlighted in 2007 at a United States congressional hearing on Gulf War syndrome. At that hearing, the late United States Air Force Brigadier General Thomas Mikolajczyk testified of his developing ALS after repeated lengthy exposure to pulsed, non-ionizing radiation as a pilot in the Gulf War. He petitioned U.S. Congress to study the connection between repeated electrical injury, prolonged electromagnetic exposure, and the subsequent development of amyotrophic lateral sclerosis, ALS. From what I've witnessed, the heterogeneity is diverse. EI's neurological sequelae has a unique prodromal ALS symptom manifestation. Without specialized training in electrical injury, symptoms can be as baffling for medical and rehabilitation providers as they are for the people living with these progressive symptoms. The late General Mick, as his colleagues called him, said, quote, "If these soldiers were dying in the field rather than quietly at home as a consequence of their service, we would leave no stone unturned. We would use the best existing resources and programs to make sure they had whatever they needed to survive," end quote. His powerful testimony at the congressional hearing caused the committee to propose the creation of a registry of people who have had ECT, TMS, and vocational or domestic exposure to non-ionizing radiation in an effort to better understand long-term consequences. 15 years later, that registry has not yet been created. Consider his plea. If our most esteemed and powerful service members face barriers to helpful interventions when they later develop delayed electrical injury, the barriers faced by common people are even greater. For example, to my knowledge, this is the very first conference presentation which directly addresses how chronic exposure to non-ionizing radiation subsequently impacts speech and communication. For that reason, I'd like to dedicate my presentation on chronic electrical injuries' impact on speech and communication to the late General Nick. I choose to answer his call to arms. I also dedicate this presentation to anyone with a history of electrical injury, struggling to gain access to desperately needed rehabilitation interventions, in particular, my late great-grandma Ruby, and my colleagues and peers living life after ECT. I'm especially grateful to Cough Drop for the invitation to present on electrical injury and communication, speech disorders. I agree with Cough Drop's mission: everyone deserves a voice. Non-ionizing radiation is likely a new term for you. I know it was for me. So what is non-ionizing radiation, and how can we be exposed to it? This graphic, created by Aaron D. Franklin, a professor of electrical and computer engineering and chemistry at Duke University, shows the electromagnetic spectrum and its sources in our daily lives. Obviously, we're all exposed to it to some degree, some of us more than others. There is an entire spectrum of exposure and consequently an entire spectrum of how non-ionizing radiation can impact speech and communication. Going forward, I will occasionally refer to pulsed high electrical and electromagnetic fields by their common name non-ionizing radiation, so that you can become more familiar with the term. Hopefully this presentation will help better understand why the FDA now requires all patients be forewarned that, quote, long-term safety and effectiveness of ECT treatment has not been demonstrated, and long-term follow-up may be necessary, end quote. But what does that mean? What does long-term follow-up look like? Why is it necessary, and who is qualified to give it? In breaking down the potential immediate and long-term speech and communication consequences of repetitive electrical injury and prolonged electromagnetic exposures, we'll focus on 6 of shock treatment's many manufacturer-acknowledged serious adverse events: cognition and memory impairment, brain injury, general motor dysfunction, neurological symptoms, visual disturbance, and auditory complications. The rate of occurrence amongst ECT recipients is unknown because modern standard practice does not require routinely measuring functional changes in every ECT recipient. Presently, the Mini Mental State Examination or Montreal Cognitive Assessment are the only recommended assessments for ECT recipients, but all speech pathologists know it takes finer assessments to identify subtle speech and communication challenges. So let's begin. What is electroconvulsive therapy, ECT, or shock treatment? It's a psychiatric treatment involving rapidly pulsing a high electric field through the brain for up to 8 seconds. This triggers a tonic-clonic, general motor seizure. It is used to treat a variety of psychiatric disorders when medication has not worked. Many of you may be surprised to hear that shock treatment is still widely used in America and worldwide. You may think it doesn't happen very often. You might be even more surprised to learn it's regaining favor in American psychiatric hospitals. Previously, it was used only in dire situations, but now it's used anytime a psychiatrist feels a patient could benefit from it. It's extremely difficult to know exactly how many people get ECT in America each year and how many treatments each patient receives. Unlike prescription drug use, there is no designated federal agency routinely auditing prescribed exposure to non-ionizing radiation.
Most people don't know shock treatment is still a thing. How many people have
What I do know is that probably about 2 million people receive ECT every year. And, so.
2 million a year?
Yeah, across the world, yeah.
You say you know that. You know the 2 million people?
I said I estimate that.
In June 2022, the UK's independent revealed electroconvulsive therapy, ECT, is prescribed disproportionately to women, who comprise 2/3 of patients receiving the treatment. In America, no one keeps track, as I mentioned previously, but one California study discovered more than 70% of the people receiving shock treatment are women, whose median age is mid-50s. But when the study was published in 2009, ECT wasn't FDA approved for kids. In 2018, the FDA approved its use on children 13 years and older. Since then, there's been a 34% increase in American hospitals providing ECT. Back in 1976, the FDA grandfathered ECT device approval without modern pre-market approval safety testing to establish electrical dosing protocols and treatment limits based on safety testing. Consequently, in 2022, both device manufacturers are facing multiple legal cases. So many legal cases that one manufacturer filed for bankruptcy after losing product liability insurance. The other chose to publish a regulatory update to the user manual. The update identified risk of what the manufacturer refers to as, quote, permanent memory loss and permanent brain damage, end quote. They also updated their cautions and warnings statement to warn ECT providers that it's the provider's responsibility to warn of brain injury, difficulties returning to work, and all other manufacturer-recognized serious risks. So how does one safeguard against those risks? That is challenging. ECT has more than a dozen unstandardized administration technique variables. These variables include things which should be taken into consideration when evaluating anyone with a history of repeated, prolonged non-ionizing radiation exposure. Let's take a look at ECT's device settings to understand what goes into generating the dose. Current strength is fixed at either 800 or 900 milliamps, depending on the device. Quote, such fixed amplitude values lack any clinical or scientific rationale, end quote. It has no officially recognized dosing protocols. Guidelines are open to interpretation. Consequently, recipient outcomes land on a spectrum ranging from short-term success to death, and everything in between. No two patients have the same experience. There are nearly an infinite number of possible outcomes. Let's look at some of the other variables involved to better understand how they relate to other kinds of electrical injuries and their broad outcome spectrum. Independent device settings include pulse width, pulse type, frequency, charge, and voltage, which is between 250 and 450 volts. The final independent device variable is percentage of power. This can be dialed from 0 to 100%. Together, these variables determine how long the fixed current is pulsed through the brain. Depending on settings, nearly an amp of current can be pulsed in hundreds or more than 1,000 pulses through the brain and nervous system for up to 8 seconds. The medications in the patient's bloodstream during the stimulus also influence how non-ionizing radiation impacts the brain and nervous system. Unlike vocational or domestic settings where people get shocked, doctors can control where the electrodes are placed. Conventional shock treatment is bilateral electrode placement. Unilateral can also be used. The preferred DILIA electrode placement puts an electrode directly over the trigeminal cardiac nerve. I will return to this later. In bilateral electrode placement, the charges focuses the anterior of the frontal lobes and brainstem. Additional variables doctors can control, which aren't controlled in domestic or vocational settings, include how much electricity was given to a patient compared to the dose needed to cause a seizure. Though some believe doctors use just enough stimulus to cause a tonic-clonic seizure, the American Psychiatric Association's textbook, The Practice of Electroconvulsive Therapy, advises between 2.5 and 6 times the electrical field strength required to cause a seizure, and 10 to 20 times the necessary stimulus in patients taking anti-seizure, mood stabilizers or other medications. Because these medications were designed to prevent seizures, so more electricity must be given to achieve the doctor's goal of triggering a seizure. Unlike electrical injuries on the job, in the home, or out in the community, doctors can control the length of time between treatments. In America, a standard index course is 10 to 12 treatments, typically given 3 times a week for 2 weeks, then twice a week for 2 weeks, and then once a week for 2 weeks. The doctor can also control the number of treatments a person endures. According to one of the most published ECT researchers, Harold Sakim, people who don't respond to psychiatric treatments are less likely to respond to ECT. He said more than 90% of ECT recipients relapse within 8 days. For that reason, he recommends what's referred to as maintenance ECT. Though some studies advise spreading out maintenance treatments, some doctors, like mine, choose to give back-to-back index courses of 3 times a week as described previously. That's common without dosing protocols or dosing limits on record with the FDA or any other international medical device regulator. American ECT recipients begin treatment expecting 8 to 12 treatments, but because improvement only lasts for as long as the patient has the treatment, ECT is one of the few medical treatments where Medicare and Medicaid do not have fixed limits on the number of treatments a patient can receive in a year or in a lifetime. Consequently, I had 116 treatments before I quit against medical advice. While that may seem like an unusually high number of treatments, there are American ECT recipients in our online support group that have had more than 200, and some who had more than 300. Recently in Connecticut, an ECT recipient contacted Disability Rights of Connecticut to get help ending court-mandated shock treatment. They discovered she had more than 500 treatments in 5 years. Begging the question, at what point does a doctor determine treatment should be discontinued? American ECT recipients begin treatment expecting 8 to 12 treatments, but because improvement only lasts for as long as the patient has the treatment, ECT is one of the few medical treatments where Medicare and Medicaid do not have fixed limits on the number of treatments a patient can receive in a year or in a lifetime. Consequently, I had 116 treatments before I quit against medical advice. While that may seem like an unusually high number of treatments, there are American ECT recipients in our online support group that have had more than 200, and some who had more than 300. Recently in Connecticut, an ECT recipient contacted Disability Rights of Connecticut to
I had repeated void. There is the slide. Back on track.
returning to electrical injury variables. Environmental conditions are ones which no one can control, not even doctors in controlled settings. Please pay particular attention to these variables when working with any person living with non-ionizing radiation injury. A simple explanation for why there are so many different outcomes among ECT recipients outside all the treatment variables is simply the size and shape of the person's head, and the length and size of their body. Historically, women have worse cognitive consequences from ECT than men. Looking at computer-generated treatments, it's easy to see how the exact same dose can have dramatically different impact on people with varying head shapes and head sizes. Perhaps part of the reason women have worse cognitive outcomes than men is because, quote, women's brains are about 11% smaller than men's, in proportion to their body size. Smaller brains allow certain features, such as a slightly higher ratio of gray matter to white matter, and a higher ratio of connections between, versus within, cerebral hemispheres. End quote. Hopefully researchers choose to answer general mixed call to audit long-term ECT outcomes. In so doing, they will begin to recognize how repetitive traumatic brain injury by repetitive electrical injury has greater long-term risks than those presently recognized. Non-ionizing radiation has the strongest impact on vascular system, nerves, and muscles in the immediate location of the shock. For example, combat veterans wearing an electromagnetic field in the form of an electronic countermeasure device to block IED transmission in a backpack disperses the medium electric field through the spinal cord, influencing peripheral nerves. Whereas ECT delivers micro flashes of high electric field strength directly to the head, having greater influence on central brain and cranial nerve function. Choosing to study Gulf War recommendations. Earlier this year, researchers audited 20 years of ECT Medicare data. They discovered people with more than 10 shock treatments have more than double the risk of developing ALS before age 65. That risk tripled in patients older than 65 with a history of 10 or more treatments. This raises questions about access to speech therapy and supportive interventions for anyone with a more than double, even triple the rate of ALS. If a single, standard index course of 10 treatments more than doubles ALS risk, why are the neurological consequences we experience not recognized by our medical community? The answer is simple. Doctors are not required to study electrical injuries, neuropathology, histopathology, diffuse electrical injury, and delayed electrical injury. Even doctors using high electric field strength to treat patients are not required to study it. This explains why humans with a history of ECT and electrical injury have difficulties obtaining referrals for communication assessments with a qualified speech-language pathologist. We have no access to testing for speech or communication disorders, and augmented alternative communication. Our injuries and symptoms are not well recognized or understood. It's important to acknowledge the study on ECT and ALS did not assess for the other neurodegenerative disorders identified by UK's Advisory Board on Non-Ionizing Radiation. Nor did it identify all neurodegenerative diseases diagnosed in people with a history of ECT. I personally was diagnosed with myoneural disorder, unspecified. This photo of me at the beach was taken in 2019. Back then, I'd already been experiencing symptoms of delayed electrical injury for 2 years. Note, I did not have a speech-generating device, though living with profound episodic dysarthria. In May 2022, a man in Australia reported his mother died earlier this year from a degenerative brain disease called progressive supranuclear palsy. He believes the disease was caused by the electroconvulsive therapy. Note, she also does not have an AAC device mounted on her wheelchair, though progressive supranuclear palsy can have a speech-language variant. A friend's daughter later developed muscular sclerosis 10 years after ECT. Several survivors in our Facebook support group are diagnosed with cervical dystonia, laryngospasm, and clinical symptom manifestation of episodic paroxysmal neuromuscular disorders. Each could benefit from a comprehensive speech and communication assessment. Many could benefit from access to alternative argumentative communication. Doctors and rehabilitation providers familiar with rare electrical injuries and their episodic paroxysmal neuromuscular disorders are few and far between. There are only 2 rehabilitation facilities in North America for people living with a history of electrical injury. In America, there is Chicago's Electrical Trauma Rehabilitation Institute. In Canada, they have Toronto's St. John Rehabilitation Centre through Sunnybrook Health Sciences, which receives funding from a variety of sources, including Electrical Contractors Association of Alberta. The good news is, Dr. Mark Yaski just moved from his position as medical director of Stony Brook in Toronto after having trained the staff there. He is now beginning to expand electrical injury services in Canada through Hamilton Health Sciences and McMaster University. The problem is, most people who begin experiencing delayed electrical injury do not have the capacity to relocate for appropriate rehabilitation. Some doctors believe that if you cannot see a large structural injury on a brain scan, then there is no injury. But doctors who specialize in electrical injury know better. Take, for example, Dr. Mark Yaski, Vice President of Research and Medical Director of the Burn Program at Hamilton Health Sciences. I'd like to thank Dr. Yaski for his tireless efforts on behalf of people with a history of electrical injuries. You can see one of Dr. Yaski's full-length presentations on electrical injury on the Life After ECT website. Let's what he has to say regarding the difficulties in diagnosing the consequences of electrical injury.
A lot of people don't appreciate the fact that electrical injuries can have severe consequences. And worsening and make it even more difficult is the fact you run all these tests and all these tests come back normal. And somebody has often an electrical injury, has headaches or migraines, you do an MRI, you do an EEG, and you don't see anything. And everybody's like, well, we don't see anything. It must be fake. It must be made up. It's not existing. Well, but that's the problem. It's not. It's real. And our tests are not adequate to detect what happens after an electrical injury. And I've seen patients that are tremendously debilitated. They can't walk, they can't speak, they can't eat. Their left side of their body is, or right side is paralyzed. They can't eat any food anymore. They have migraines. They can't focus. They can't sleep. They have no energy. They do take 2 steps and they're exhausted. They have seizures. So I can give you a battery of symptoms of 80, 90, 100 symptoms. And if you ask somebody who is not educated and not aware about what electrical injuries can do, they will all look at you as like, let's do some tests. Let's run this battery of tests. And it all comes negative. And they were like, well, no, it doesn't exist. And this is the challenge the electrical community faces, the recognition that it is an injury pattern that can't be detected, and only somebody who is educated and experienced in this area can make this call.
Neurons communicate by passing approximately 2 to 4 milliamperes electric current back and forth. When the body is exposed to greater than 2 to 4 milliamps, the body's self-preservation mechanism diffuses strong current along the nerves and blood vessels in an ionic tidal wave through the entire nervous system, hence the term diffuse electrical injury. Even low-voltage shocks, which initially seem harmless, over time, nerves and blood vessels in the immediate location of the shock can have the greatest changes in function. Diffuse electrical injury causes damage to more than just directly where the person was shocked. I will show you some computer-generated examples of diffuse electrical injury later in this presentation. Not all electric fields are powerful enough to cause injury. Pulsing significantly more current through a nerve designed to carry just 2 to 4 milliamps can cause harm. Injury can occur in a flash, just a millisecond, of a high field of electric strength, especially when those pulses rapidly alternate polarity for the length of the exposure. For example, in just 7 seconds, an ECT machine can generate more than 1,000 pulses, alternating positive and negative polarity. Injury can also be caused by prolonged, lengthy exposure to a medium field of electric strength. Small electrical fields are not yet recognized as causing damage to people without a history of chronic non-ionizing radiation exposure, but small fields sure can do fun things to hair. The body transfers electronic messages across cell membranes by exchanging electrolytes through voltage-gated ion channels. Repeated exposure to pulse, high-energy fields, changes how the body uses sodium, potassium, calcium, other electrolytes and ions. This disrupts how messages are passed through the nervous system and muscles. The body transfers electronic messages across cell membranes by exchanging electrolytes through voltage-gated ion channels. Repeated exposure to pulse, high-energy fields, changes how the body uses sodium, potassium, calcium, other electrolytes and ions. This disrupts how messages are passed through the nervous system and muscles. Electrical injury changes ion channel function. This is known as acquired channelopathies. Gradually, the body loses ability to regulate electrolytes. Channelopathies cause episodes depending on which electrolyte the body is struggling to process. Symptoms can include a broad spectrum of episodic sudden onset neuromuscular symptoms. These episodic muscular symptoms are typically seen in genetic diseases. These sudden onset events can include symptoms like migraine, seizure, paralysis on one side of the body, tetany seizures, full body weakness, writhing movements, muscle spasms, muscle twitching, involuntary muscle movements, and cardiac arrhythmia. Symptoms can resolve as quickly as they hit. Sometimes they last for several minutes, other times several days, depending upon how long it takes the body to regain homeostasis. Over time, there is a progressive loss of ion channel function in electrical injury patients. Episodes happen more frequently, and people begin losing the ability to fully recover after an episode. We don't know if that's because ion channels continue to deteriorate, or if it's because with the loss of regulation, surrounding cells slowly lose capacity to regulate ion channels. It may be a combination of both. Acquired channelopathies cause what's known as acquired episodic paroxysmal neuromuscular disorders. Usually, channelopathies are rare genetic disorders isolated to one or two kinds of ion channels, like primary periodic paralysis, hemiplegic migraines, or fainting goat syndrome. Since non-ionizing radiation affects all ion channels, astute clinicians may witness clinical symptom manifestation of genetic neuromuscular diagnoses mentioned above, and even episodic chorea, episodic dystonia, migraines, arrhythmia, all in the same patient, depending on what ion their body is struggling to regulate. When ion channels struggle to function well, nervous system activity is compromised, short-circuited if you will, and episodic paroxysmal neuromuscular symptoms can arise, altering muscle tone, strength, and coordination. Unfortunately, not many clinicians are familiar with rare neuromuscular disorders caused by channelopathies. People with familial forms of these disorders can experience symptoms for 10 to 15 years before getting accurate diagnosis using genetic testing. Gratefully, doctors are beginning to recognize that all genes causing these disorders have yet to be mapped and encourage patients to track symptoms and triggers, especially ones impacting speech, communication, coordination of muscles, and muscle tone. When cell membranes are exposed to rapidly pulsed, medium, or high electric fields, it creates tiny holes in the cell membrane, in a phenomenon known as electroporation. This allows anything outside the cell to get into the cell. During ECT, this allows medicine and anything else in the bloodstream to be delivered at the cellular level, amplifying effects. Where the electrical fields are strongest, pores are too large to heal. The cells take on water and lose their contents. Though they try to keep up, eventually they cannot, and cells die. Basically, these holes cause cells to leak ions. This is referred to as irreversible electroporation. Initial damage is isolated to the path that receives the highest electrical fields. As time progresses, surrounding cells, previously dependent on damaged cells, no longer receive nutrition, pulses, or oxygen. Slowly cells starve and begin to die off, causing additional degeneration. Though typically used for tumor ablation, one article on brain cancer treatment explained they chose to use the low end of electric field parameters outlined in the American Psychiatric Association's Electroconvulsive Therapy Handbook. When I read that, I stared, in disbelief, thinking about my own brain stem, having nearly an amp pulse through it, more than 100 times, rupturing chronic microbleeding in the central pontine area. "47. But how are electrical injuries classified as brain injuries? The answer may surprise you. Electricians, welders, and others exposed to repetitive, prolonged, intense non-ionizing radiation have acquired brain injuries that can be broken down in the following ways. It is technically an acquired brain injury because individuals were not born with these injuries. Since an external electrical force caused a seizure, the absence of brain activity in a coma, electrical injuries are technically a traumatic brain injury, even when prescribed by a doctor. Traumatic brain injuries are broken into 3 categories by the U.S. Department of Defense, depending on how long the loss of consciousness lasts. If it is less than 30 minutes, it is a mild traumatic brain injury. Moderate TBIs are defined by the Department of Defense as those which have a loss of consciousness lasting more than 30 minutes, but less than 24 hours. Loss of consciousness lasting more than 24 hours is qualified by the DoD as a severe traumatic brain injury. Keep in mind that, like a concussion, cellular damage is invisible on standard brain scans. Let's talk repetitive traumatic brain injury from shock. ECT is rarely a single event. The more a person has, the worse the outcome. Acute or index courses are typically 3 times a week in America, twice a week in England. Can you imagine sending an athlete with a brain injury back into play before they healed? We now understand how dangerous that is. ECT injury is referred to as mild to moderate TBI, based on the length of time the person is unconscious. A human brain's response to electrical injury is outside the doctor's control. Though the person was given fast-acting anesthesia, it wears off in 2 to 5 minutes. But the person remains unconscious due to the seizure, followed by the absence of brain activity, which subsequently restarts as coma activity. The person can be unconscious for 15 to 45 minutes, or longer. Just like a concussion, microstructural cell damage cannot be seen on standard brain scans. This picture is from an actual ECT neuropathology study. This study is extremely old, published in the 1950s, before they began using anesthesia and paralytics. The reason this photo is so critical to understanding modern ECT comes in the understanding that anesthetics are typically used to stop uncontrollable seizure activity. This means modern ECT must use an electrical field 4 to 6 times stronger than the electrical field which caused the hypertrophy and hyperplasia of astrocytes around irregularly dilated blood vessels, found in this old neuropathology slide of an ECT brain. I'm genuinely curious what my brain will look like at autopsy under a microscope. So, how can we better understand the damage caused by repeatedly exposing the brain and nervous system to high electric fields? I'd like to introduce you to Dr. Bennett Omalu. He's a forensic neuropathologist, the coroner who first identified chronic traumatic encephalopathy in American football players. Will Smith played him in the movie Concussion. For decades, our nation's football players were told that repetitive concussions and subconcussive events did not have long-term consequences. Thanks to the work of Dr. Bennett Omalu, we now understand even repetitive mild traumatic brain injuries have a cumulative effect. Dr. Omalu explained ECT injury during a brain injury advisory board meeting for the state of California's Department of Rehabilitation. He confirmed repetitive head trauma causes functional injuries. These aren't readily seen on standard brain scans. But the neuropathology of electrical injury and people with a history of ECT are easily recognized under a microscope. He said it causes extensive functional changes. They must be considered in the context of both an electrical injury and repetitive head trauma. He explained, the natural laws governing electricity do not change based on a doctor's intent. Let's take his advice. Using more than 200 times the electrical stimulus than the nervous system is designed to use causes a seizure so violent, it consumes all the brain's energy, shutting off all brain activity until the brain can recover. In ECT, brain activity silence, referred to as postictal suppression, happens after the seizure. Doctors cannot control how long the brain turns off. Everyone responds differently to such high electric fields. Some people's brain activity stops for as little as 22 seconds. Other people, exposed to the exact same electric field, have an absence of brain activity for 6 minutes and 40 seconds. Without brain activity, the lungs are not pumping oxygen through the brain, and the brainstem's ability to regulate heart rate is compromised. Electricians, welders, combat veterans and other people with electrical injury typically don't have someone next to them to hook up an EEG and measure brain activity when an electric shock induces a seizure. You may be surprised to learn that ECT medical devices are equipped with an EEG, but it only measures how long seizure activity lasts and then automatically turns off when the seizure ends. Doctors are not required to document how long brain activity silence and coma lasted. It varies in every patient. The same patient can theoretically have a different length of brain activity silence after every single treatment, based on the variables mentioned previously. During ECT, the patient has an oxygen mask on, but there's no brain activity to breathe it in, and respiratory muscles are paralyzed, without mechanical support to inflate the lungs properly, until the paralytic wears off completely. Acutely slowed heart rate is common in ECT. We know that with impaired oxygen circulation and erratic perfusion, cell death begins at 4 minutes. This is an anoxic brain injury. Paralytics used in ECT impact respiratory muscles and take between 4 and 10 minutes for the half-life to pass, depending on the patient. Insufficient oxygen causes hypoxic brain injury. One ECT survivor, a colleague of mine, had 8 ECT treatments in 2001 when she was 25. After living with speech problems and other consequences of repeated electrical injury for more than 20 years, in May 2022, she finally gained access to a specialized functional MRI used to measure repetitive brain injuries. This specialized scan is called functional neurocognitive imaging. As a 46-year-old female, these results demonstrate the tiring effort involved when communicating. On this scan, green is normal brain function. Yellow, orange, and red indicate greater than normal functional activity required to complete the verbal fluency category test. To hear her speak, undiscerning doctors and allied health professionals might not recognize that she lives with cognitive communication disorder. These results visually demonstrate how tiring communication can be. Speech and communication problems become more apparent as neurocognitive fatigue sets in. From personal experience, part-time use of a speech-generating device can help alleviate the heavy burden of cognitive communication disorder. For this reason, I respectfully suggest early access to alternative augmentative communication. Not only is speech loss episodic, electrical injuries brain injury means it's absolutely necessary to have as much time as possible to practice using a speech-generating device. Lengthy repetition is the only way an ECT-injured person can consolidate the learning process into their long-term memory, enhancing communication if the muscle strength and coordination continue progressive decline. Even long after the initial injury, appropriate comprehensive speech assessments and rehabilitation interventions can improve speech and communication disorders in people living with electrical injury. For example, the photo on the left shows functional neurocognitive imaging 20 years after electroconvulsive therapy. The photo on the right shows functional neurocognitive imaging in the same patient after 2 weeks intensive enhanced performance in cognition, outpatient TBI treatment program, using a multidisciplinary approach to post-concussion symptoms. As you can see, intensive multidisciplinary rehabilitation improves neurocognitive functioning, consequently improving speech and communication deficits, among other things, which improved quality of life. Exposure to non-ionizing radiation can potentially have both immediate and long-term consequences on speech and communication. When a person is initially exposed to non-ionizing radiation, they may have difficulty finding words, experience selective mutism, and even slur their speech when overstimulated or tired. If the individual had speech and communication concerns prior to non-ionizing radiation exposure, they may experience a regression in speech. For example, one mother of a young man born with Down syndrome, autism, and mild cerebral palsy reported that when her son began electroconvulsive therapy, he lost some language skills, and he had garbled speech. We know even a single mild traumatic brain injury can cause speech and communication problems, best addressed by comprehensive assessment and rehabilitation. Though some hypothesize aphasia is a rare event, how often it happens is really unknown because comprehensive speech assessments are not routine for ACT recipients. Iatrogenic diseases generally go underreported by doctors. For that reason, it's critical that we pay attention to people with a history of repetitive electrical trauma. In the online support group, difficulty finding words is frequently reported immediately after ECT. Without rehabilitation, some never regain the ability to speak effortlessly after electrical trauma. Slurred speech caused by subsequent motor and muscle coordination problems impact speech in people with a history of shock treatment becomes easier to conceptualize when considering a very obvious site involved by stimulation during electroconvulsive therapy is the trigeminal area, which is located directly beneath the right electrode in the DeLia placement. It would certainly be of no surprise that a current flow of 900 milliamperes and a frequency of typically 10 to 70 Hz lead to a massive irritation of the trigeminal nerve. Chronic irritation of the trigeminal nerve apparently leads to both the failure of segmental inhibition in the trigeminal nucleus and ectopic action potentials in the trigeminal nerve. Consequently, the trigeminal nerve and vagal nerve are both permanently altered by ECT. These nerves regulate how the body receives sensory input. Additionally, that ionic tidal wave of current I mentioned before overflows through the brainstem, impacting other cranial nerve function. Understanding this connection may explain why ECT recipients' ability to produce intelligible speech changes when overwhelmed by sensory input. From personal experience, and that of my peers, initially after treatment, our speech may sound slurred when we're exposed to a lot of sensory input. If we are overexposed to sensory input, we can experience complete verbal apraxia, knowing what we want to say, but unable to connect motor function and muscle coordination to speak. As the person ages, slurred speech and complete verbal apraxia will gradually be triggered by more innocuous sensory stimulation. With the passage of time, episodic slurred speech progresses to episodic dysarthria, interspersed with episodes of complete verbal apraxia. With progression of delayed electrical injury, in advanced stages, the voice becomes more hoarse as we see with motor neuron disease. Ultimately, residual voice becomes weaker until, like other myoneural disorders, the person is left without functional speech. Diffuse electrical injury alters nerve and vascular function, not only impacting trigeminal nerve and vascular system, but also surrounding nerves and vascular systems. For example, this computer simulation demonstrates current density for bilateral and unilateral electrode placement. Notice how the vascular and nervous system is impacted through the neck and shoulders. It actually extends well beyond that, as we'll see in a minute. Energy crammed into a smaller space diffuses through the body around it, causing significant microstructural damage. The size and shape of a person's head, mouth, tongue, and neck play a significant role in a person's subsequently developing speech disorders with the onset of delayed electrical injury. Given all the variables involved in electrical injury and the episodic nature of symptoms, literally no two people who show up in a clinic for help will have precisely the same symptom manifestation. For that reason, symptoms must be carefully tracked over time. Additionally, altering trigeminal nerve function with repeated electrical injury may explain why some electrical injury survivors in our support group report tinnitus, hyperacusis, dizziness, and vision complications. In my experience, the more visual and auditory stimulation I am exposed to, the faster my speech and communication break down. Maybe studying how ECT's acquired sensory processing disorder impacts speech production can lead to understanding why sensory input triggers speech and communication breakdown in others living with congenital verbal apraxia. Again, not all electrical injuries are the same. So people with electrical injury may, or may not, develop a variety of speech and communication disorders immediately after the injury. They may, or may not, develop delayed electrical injury. Electrical injury's neurological sequelae can be baffling. It's initially an episodic neuromuscular disorder, driven by electrolyte dysregulation in the form of acquired channelopathies. One day your client may have profound dysarthria or even verbal apraxia, and at the next appointment, under different circumstances, speak effortlessly. May be better rested, hydrated, or less stimulated. They will still report minutes, hours, or even days of profoundly undistinguishable speech, or connect their brain to their voice altogether when overwhelmed by sensory input for extended periods of time. Symptom inconsistency can be baffling to clinicians unfamiliar with the ebb and flow that influences metabolizing electrolytes over the course of a day, week, month, or weather season. I apologize for this graphic image. It is from a study examining how the pulsed high electric field is distributed through the body when shock treatment is given to a pregnant mother to identify whether the pulsed high field reaches the child. This graphic is particularly helpful to understand how the pulsed high electric fields impact the mother's brain, face, and neck, all critical components for communication and speech. As you can see in the green area, it's entirely plausible that the child may also develop speech coordination issues at some point in their life. Though this study focused entirely on fetal brain impact, it illustrates how corresponding current density is strongest on the nerves and muscles required to communicate, swallow, regulate heart rate, and respiration. These essential daily living tasks are most heavily impacted by disrupting electrolyte exchanges in nerve function closest to electrical trauma. Electrical injuries cause an entire spectrum of speech and communication problems. One brain injury adage says, if you've met one person with a brain injury, you've met one person with a brain injury, because we all have unique symptom manifestation. This is just as true for people with a history of electrical injury. If you've met a person with an electrical injury, you've met one person with an electrical injury. But if you track us over a long period of time, the similarities of our clinical symptom manifestation will become obvious when looking at us as an entire group. What do speech and communication problems associated with electrical injury look like? Well, it depends on when you meet the patient. Since researching electrical injuries' impact on communication and speech is new, I can only report my personal experience, that of those in our online support group, and personal conversations with electricians and other humans with a history of electrical trauma. Initially, during the course of electroconvulsive therapy, or soon after a person is shocked at home or on the job, they report difficulty with word finding. This is a natural consequence of brain injury. We might drop small words or confuse words. We might recognize that we use the wrong word, but have difficulty finding the right one. Sometimes we throw a word into a conversation which starts with the same letter of the word we intended, but makes no sense, and the minute we say it aloud, things can get embarrassing. Many times we sit, knowing the concept of what we want to say, and cannot find the words to express it. When writing, we spell things phonetically, or we use homophones, two words that sound the same, but are spelled differently. Like all brain injuries, repetitive brain injuries grow worse with age. The delayed nature of electrical injury means speech and communication problems will change over time. Many who live with these symptoms are isolated from society due to the absence of rehabilitation support and sheer embarrassment. If you're wondering how early access to a reliable speech-generating device and consistent support in learning how to use it can improve quality of life, I'm the evidence. Comprehensive language and speech interventions made a dynamic difference in my life. Electrical injury specialists recognize and expect delayed electrical injury. Its impact on speech is unique to other recognized speech and communication disorders because symptoms have an episodic, paroxysmal, neuromuscular component. There are a variety of episodic disorders of the brain caused by channel mutations. Though these mutations were once recognized as only genetic, we now know electrical injury causes mutations and ion channel dysfunction. Though delayed electrical injury is not yet fully understood, there are several recognized theories involving vascular damage, chronic ischemia steadily harming tissue it supplies, chronic inflammatory reaction, oxidative stress, electrostatic separation of tissues, and electroporation of neurons, free radicals from oxidative stress, leading to demyelination. And trauma's cortisol release augmenting hyperstimulation of glutamate receptors. In studying this, each of these theories makes sense. For that reason, I refer to delayed electrical injury as the cumulative effect, a consequence brought about by all of it together. But until now, the cumulative effect of electrical injury on speech, communication, and other motor functions has limited recognition, isolated to electrical injury specialists. This is likely because the length of time between being shocked and episodic symptom onset can be lengthy. Episodic neuromuscular speech problems will be more obvious in those with a history of electrical trauma to the head because the vascular and motor function is most impacted closest to the electrical contact and exit points. Consequently, people with a history of electroconvulsive therapy are best equipped to help us understand electrical injury's impact on speech. Delayed electrical injury can cause episodic dystonia or episodic ataxia. Laryngospasms can be caused by myotonia from sodium, potassium dysregulation, and demyelinated nerves. Apraxia or general motor dysfunction from dysregulated ion channels impact trigeminal and vagus nerve function, overflowing into the laryngeal nerve associated with coordinating muscles to speak, breathe, and swallow. As delayed electrical injury progresses, these episodes become more frequent. Vocal cord dysfunction and motor neuron disease or amyotrophic lateral sclerosis can manifest as hoarseness, dysphonia, a non-explosive cough, laryngospasm or stridor, myoclonus in tongue, mouth, or neck/throat. Episodes will gradually become more frequent with less capacity to regain full function, ultimately resulting in complete loss of residual voice, typical in people with myoneural disorders, like motor neuron disease and muscular sclerosis.
These are some of the triggers. They include sensory flooding, rapid weather or temperature changes, foods with high bile content, neurocognitive fatigue, multiple chemical sensitivity, hyperelectrosensitivity, alcohol, caffeine, green tea, coffee, stress, amino amines, and other meds that block ion channel function.
The problem is, medical professionals less experienced in electrical injury are often baffled when a client shows up to discuss serious speech concerns, not clinically manifesting during the initial appointments. This happened to me when I began experiencing initial signs of delayed electrical injury. After losing speech for hours at a time, before I began recognizing symptom triggers, family would either take me to the ER or make an appointment during acute symptom onset. But then when the follow-up appointment with neurology finally came around, I would be symptom-free and doctors would stare at me in disbelief. Some even rolled their eyes. Initially, episodic paroxysmal neuromuscular symptoms brought on by repetitive electrical injury were labeled by doctors unfamiliar with electrical injury as a conversion disorder or functional neurological disorder. Both are diagnoses of exclusions, but it can be tempting to prematurely diagnose, without a time-consuming differential diagnosis, when symptoms aren't understood. Unlike a stroke or other form of brain injury, the consequences are not initially constant. The only way to properly recognize them is to track episodic symptoms over time to begin elucidating the pattern. This well-recognized strategy is most effective for properly identifying any form of episodic paroxysmal disorders to get appropriate support. For example, now, let's watch some video case studies of people living with delayed electrical injury to better understand how it can impact speech production. The problem is, this video shows an episode of verbal apraxia triggered by episodic dystonia. In the early morning, before recording this video, I only spoke with a slight lisp. After an electrolyte shift from changes in hydration and metabolizing food, my ability to communicate orally is drastically impaired for an hour or 3. Notice how it's the muscles closest to the ECT electrode placement that are most severely affected. In this particular episode, my hands are not impacted. I can still communicate with American Sign Language. This information is particularly helpful in evaluating how an electrical injury recipient can access communication. Since dystonia most profoundly impacts my face, neck and shoulders, like the computer-simulated images you saw, at this time, I can still use a keyboard to activate my speech-generating device during this particular form of an episode. Here's the video.
What happened when I can't hold? But
The further removed from shock, the more profoundly electrolyte shifts become obvious. In this video, my body is struggling to metabolize a different electrolyte than in the previous example. Instead of dystonia, I experienced the opposite, weakness and paralysis, especially in the area closest to where I was repeatedly shocked. About 90 minutes before this video, I'd eaten an artichoke. Later I learned artichokes have a high thiol count. Thiols influence how the body regulates electrolytes and other ions. Foods with high thiols activate their regulatory behaviors that result in the production of reactive oxygen species resistance proteins, known as ROS, which damage lipids, proteins, and DNA. Thiols regulate vascular function as well. In this video, you can see how profoundly a person with a history of electrical injury can be impacted by high thiol foods. Now that I am well into delayed electrical injury, I've become a canary in the coal mine. In me, high thiol foods acting on acquired channelopathies trigger weakness and even paralysis in the muscles most injured by electricity. In this case, I was so weakened, I couldn't even sit up. It took me nearly an hour to type the text for this brief video. This is a graphic demonstration on how foods with high thiol count can impact speech and communication. Once I figured out thiols changed my nerve's ability to function, I eliminated foods with high thiols from my diet to reduce the severe roller coaster ride caused by my nervous system's inability to regulate my electrolytes. By doing so, I seem to have taken the brake off the accelerator of my progressive deterioration. Oxidative stress impacts degenerative diseases, so eliminating high thiol foods just might be something to explore in an effort to slow deterioration and preserve residual voice, muscle strength, and coordination for as long as possible. Here's the video.
Please excuse my artificial voice. I am nonverbal today. I have an episodic paroxysmal neuromuscular disorder. I suspect I may be having difficulty regulating electrolytes like chloride and calcium in certain vegetables when eating them at this quantity. I'm still figuring out which are safe. 90 minutes ago, I ate a full artichoke. Now I have no muscle tone and muscles coordinating my speech, and need to talk to my doctor about pacing the vegetables. This is my daily life. I want my health. Why? So that I can improve, not only my own quality of life, but also the quality of life for the hundreds of thousands in my situation worldwide. I am a survivor of repeated electrocution. I have hundreds of peers, slowly deteriorating like me. We need help. I lead an international patient safety advocacy group to break down barriers for comprehensive brain injury assessment for people with a history of repeated electrical injury. They look to me for answers and leadership, because I used to be a university professor of clinical rehabilitation. I need to get healthy so I can complete my life's purpose.
This video shows an episode of trigeminal laryngeal dysfunction in the form of a laryngospasm, which lasted in varying intensity roughly 90 seconds. It halted speech and disrupted breathing. Like all spasms, it can go away as fast as it begins. Sometimes it reoccurs. Laryngospasm occurs because of mechanical or chemical irritation of airway structures leading to efferent stimulation of the trigeminal and vagus nerves, resulting in activation of intrinsic adductor musculature of the larynx. People who experience laryngospasms in the form of spasmodic dysphonia identified evidence of segmental demyelination of cranial nerves and rare axonal degeneration. There are several cranial nerve syndromes with differing manifestations depending on the nerve involved. Demyelination is a commonly recognized consequence of electrical injury. My laryngospasms are likely secondary to demyelination of trigeminal and vagus nerves. Bringing it back to myoneural disease, episodic laryngospasm is common in motor neuron disease, reported by 19% of patients. Here's the video.
Went away.
This is a fourth example of my speech problems. As you listen to this video, you can hear how hoarse my voice is, mixed with the dysarthria from difficulty coordinating my muscles. By way of explanation, this video was taken in 2019, when I was bedridden, in response to a tweet from a psychiatrist never trained in electrical injury. He said some people just have a bad experience with shock treatment. The video was taken before I learned about the environmental triggers playing a role in my rapid decline. Avoiding them allowed me to regain some function. Here's the video.
Smear my bad experience with psychiatry's treatment is costing me my life, but I promise you I will never act disrespectfully. But you have to take us seriously because we need your help.
This fifth video was sent to me by a young woman in her late 20s who had 5 treatments in 2020 using unique electrical dosing medical device settings. This video was taken roughly 18 months after her ECT. She sent them to me with a message that stated in part, "I've been dealing with some swallowing difficulties for over a year now, but everything seems to have progressed quickly these past few months. My motor symptoms seem to have affected my face, tongue and bulbar muscles first, which really scares me. Every time I eat, I have food go up my nose and I get this painful pressure in my chest that only goes away after coughing up whatever was in my airway." Let's take a look at her video. What do you see? This sixth video was sent to me by a young woman who had more than 60 ECT treatments as a teenager. She is now in her 30s. At this time, her delayed electrical injury causes acute sensitivity to environmental factors. This particular episode was triggered by taking a seemingly innovation over-the-counter allergy medication as prescribed for seasonal allergies. She routinely took her allergy meds as prescribed without any problems until she developed delayed electrical injury years after all psychiatric medications were out of her system. This system does away once the allergy med is out of her system. Here's her video. Keep in mind, it is playing at normal speed. What do you see? When identifying appropriate, alternative augmentative communication for people with a history of electrical injury, there are several things to consider. Does the person have an acquired visual processing disorder? How easy is it for them to read and process information when they are tired or symptomatic? How does working memory impact their ability to locate desired words and phrases? How do changes in neuromuscular tone affect their ability to access their device? For example, when experiencing an episodic hemiplegic migraine, weakness, paralysis, spasticity, or a lengthy episode of dystonia. Keep in mind, your client's symptoms were caused by a non-ionizing radiation injury. They likely have problems with hyperelectrosensitivity. This means, in using an AAC device, they are further irritating an established injury by sitting in close proximity to non-ionizing radiation emitted by their device. Lengthy exposure to their speech device may potentially make things worse. I recently trialed an AAC device with infrared eye tracking. Over the course of my 2-hour trial, I began losing residual voice, had increased spasticity in fingers and arms, and gradually began having problems coordinating the muscles required to breathe and swallow. This may be a consequence of ionic leak caused by electroporation, or maybe vasodilation from low-level infrared, or maybe a combination of the two. Electrical injury can cause vascular abnormalities in the brain. I have chronic microclete or telangiectasia in my brainstem. Bluetooth and Wi-Fi also present problems for people who live with hyperelectrosensitivity. Identifying an AAC device with the lowest EMF output and using wired keyboards, wired speakers, wired switch, or camera-activated devices when a keyboard is no longer accessible will reduce fatigue and enhance cognition in people with a history of extensive non-ionizing radiation exposure. It just might slow progressive deterioration by reducing irritation to cellular membranes.
So this is my call to action. We need automatic referrals for comprehensive speech assessment. We need routine lifetime follow-up to identify delayed symptoms that we need you to listen to us and presume competence. We need to fund studies of speech and communication in people with non-ionizing radiation injuries. We need resources for adults living with acquired speech disorders and their family members or caregivers, because most available researchers are made for children. We need access to AAC, and please remove barriers to voice banking, because by the time we get help, it might be too late. So for more information on life after shock treatment or other electrical injury, you can see our website at lifeafterect.com. If you would like to help people like me gain earlier access to speech therapy and other forms of rehabilitation, please sign my website. What's it called? Petition at change.org/patient safety ECT. Thank you so much. Thank you for the opportunity to share my experience. And thank you for working to help people like me, because we need your help. You can see all of the references by downloading the PDF with the script. I apologize because my brain injury made it a little repetitive, but gratefully, we are getting the message out there.